Welcome to this revision deep dive. If you are a surgical resident tuning in, you already know the clock is ticking.
Yeah, and we are not here to waste your time with long introductions or, pleasantries today.
Exactly. Our mission today is highly specific. We are mastering the clinical management of ambiguous genitalia and intersex disorders.
Right, and this material is strictly targeted for those of you preparing for board exams, specifically like the FRCS and plastic surgery.
So we are going to use a direct question and explanation format to distill the high-yield facts you absolutely need to know from the established clinical guidelines.
Spot on. And while we are focusing on the facts required to pass an exam, it is crucial to keep the broader context at the forefront of your mind.
Because it's not just theory.
No, not at all. Understanding these complex developmental pathways isn't just about ticking the right box on a multiple-choice paper. It is about safely managing sensitive, highly complex pediatric emergencies.
The emergencies that will ultimately define your competence and your bedside manner as a plastic surgeon.
Exactly.
So, if we are looking at the broad spectrum of these presentations, how do we systematically categorize them in our minds? When that initial consult comes in, we need a mental framework.
You definitely need a framework.
What are the four main categories of ambiguous genitalia that ground our entire diagnostic algorithm?
Right, so you need to divide them into four distinct clinical buckets early on. First, you have masculinized female.
Okay, masculinized.
Second, the under-masculinized male. Third, disorders of gonadal differentiation. And fourth, true hermaphroditism.
Four buckets.
If you can categorize a clinical presentation into one of those four buckets early on, you are already halfway to the correct management plan.
Let's focus on that first bucket then, the masculinized female. Specifically, I want to zero in on the most common cause overall, which is congenital adrenocortical hyperplasia, or CAH.
A huge topic for the exam.
Huge. So what is happening at the genetic and pathophysiological level that leads to this specific presentation?
Well, with CAH, which is sometimes referred to as female pseudohermaphroditism or adrenogenital syndrome, we are dealing with a patient who is genetically female.
So the karyotype is 46XX.
46XX, exactly. And the core pathophysiology here usually comes down to a deficiency in a very specific enzyme, which is 21-hydroxylase.
And 21-hydroxylase is one of the terminal enzymes required for glucocorticoid synthesis, right?
Yes, it is.
So if we think about this conceptually, if that enzyme is missing, the normal production line is completely halted.
Precisely. Because that 21-hydroxylase enzyme is absent, the body just cannot complete the synthesis of glucocorticoids.
Right.
As a result, you get a massive buildup of steroid hormone intermediates upstream of that missing enzyme. The body still has to do something with all those precursors, so they are diverted down the only biochemical pathway left open to them.
Which is the testosterone synthetic pathway.
You got it.
Think of it like a dam blocking a river. The normal glucocorticoid pathway is blocked by that missing enzyme, so the water, or in this case, the steroid precursors, floods over into the only open spillway, which is testosterone synthesis.
That is a perfect way to visualize it.
So clinically, you have a patient who is genetically female, but who is suddenly flooded with testosterone precursors in utero.
Flooded with them. And before we even discuss the anatomical changes, we have to highlight a crucial, high-yield clinical reality. Because of this specific enzyme deficiency, 75% of these patients also have a concurrent aldosterone deficiency.
75%. And that leads to severe salt wasting.
Yes. Acutely, in the neonatal period, this salt wasting can present as profound dehydration and a full-blown adrenal crisis.
Which is a life-threatening medical emergency.
Absolutely. Stabilizing the patient medically takes absolute precedence over any surgical or anatomical considerations. You cannot rush to the OR.
That is a massive red flag to watch out for in a clinical vignette on the boards. You have to recognize the medical emergency first. So assuming the neonate is medically stabilized, what physical phenotype are we looking at, and what does the long-term management strategy involve?
Well, the external genitalia can vary significantly depending on the degree of testosterone exposure. It can range from a mildly enlarged clitoris all the way to a completely normal-looking penis with a terminal meatus.
Wow, so a huge spectrum.
A very wide spectrum. However, the standard of care is that these children should be raised as female. They have normal internal female reproductive organs and are usually fertile.
And medically?
Medically, because of that blocked pathway we discussed, they will require lifelong hydrocortisone or fludrocortisone to manage the adrenal insufficiency.
And from the plastic surgery perspective, what are the surgical interventions and the specific timelines we need to know?
Surgical correction is usually necessary to feminize the external genitalia to align with the gender assignment and internal anatomy. This typically involves a clitoral recession and a vaginoplasty.
And the timeline.
The key timeline to memorize for your exams is that this surgery is generally performed between 3 and 6 months of age.
3 to 6 months. Okay, so we've established the presentation for a genetic female flooded with androgens. Let's flip the script and look at the second bucket, the under-masculinized male.
Right, moving on to the XY patients.
Exactly. What are the genetic baselines and the specific physiological failures at play here?
In this category, the patients are genetically male. The karyotype is 46XY. But, as the name suggests, there's inadequate masculinization of the external genitalia.
Now, there are 4 specific causes we need to track, right?
Yes, 4 specific physiological causes you need to be able to identify. First, Leydig cell aplasia. Second, a deficiency in any of the 5 distinct enzymes required for testosterone synthesis.
Let me make sure I'm visualizing this right. If the goal is to produce and utilize testosterone, we can think of it like a factory. Either the factory is missing the workers entirely, which would be the Leydig cell aplasia, or the assembly line itself is broken due to those missing enzymes.
That works perfectly.
What are the other 2 causes?
The third cause is a deficiency of 5-alpha reductase. Now, normally, 5-alpha reductase is the enzyme that converts testosterone into its much more potent active form, dihydrotestosterone.
Right.
Without that conversion, masculinization simply stalls. Finally, the fourth cause is androgen insensitivity syndrome.
Ah, androgen insensitivity.
Yes. In this scenario, the hormones are actually present in the bloodstream, but the body's peripheral receptors simply do not respond to them. This ultimate failure to process the hormone results in female external genitalia.
To stick with the factory analogy, 5-alpha reductase deficiency means you can't upgrade the product to its final working form. And androgen insensitivity means you are shipping the final product out, but the delivery address simply isn't accepting the packages.
Exactly. The receptors are offline.
So we have a 46XY karyotype, but inadequate masculinization. What does this mean for gender assignment and surgical intervention?
These children are generally raised as female. The clinical reasoning is that they would always have an inadequate phallus for male sexual function, and in cases of androgen insensitivity, there is likely an underlying androgen resistance in the brain tissue as well.
And the surgical management for these patients?
Surgery for the under-masculinized male, raised as female, involves vaginal dilatation and an orchidectomy to remove the internal testes.
Now, here's a fascinating nuance regarding the timing of that orchidectomy that examiners absolutely love to test on. It completely shifts how we think about surgical staging.
It does. It is a highly debated topic in clinical practice right now. Some experts strongly advocate delaying the orchidectomy until after the patient goes through puberty.
And why is that?
If we look at the underlying biology, keeping the testes intact allows them to produce estradiol. That naturally produced estradiol is actually what drives the feminine physical changes of puberty.
So you're leveraging their own gonads.
Exactly. Delaying the surgery allows the patient's own biology to facilitate a more natural pubertal transition, reducing the need for exogenous hormones during that critical developmental window.
Wow. So delaying the surgery actually lets their own biology do the heavy lifting for puberty. That is a massive shift in how you'd normally think about surgical timing, and definitely something to keep in mind for the boards.
Definitely.
Let's look at the third category, disorders of gonadal differentiation. I want to break down the second most common cause of ambiguous genitalia overall, which falls right into this category. I'm talking about mixed gonadal dysgenesis.
Mixed gonadal dysgenesis is a classic presentation you need to know inside and out.
Let's look at the anatomy first.
In these patients, the gonadal development is profoundly asymmetrical. A testis on one side develops normally, though it is very often located intra-abdominally rather than descending.
Right, and the other side.
The gonad on the opposite side does not develop properly at all and simply becomes what we term a streak gonad.
And what are the genetics driving that asymmetrical development?
The karyotype for most affected children is usually a mosaicism, presenting as either 46XY or 45XO.
Okay, we need to pause here because there is a massive oncological risk associated with mixed gonadal dysgenesis that you absolutely cannot miss on a board exam or in practice.
This is critical. You have to pay attention here. The normal testis in these patients has a severely elevated incidence of developing a gonadalblastoma.
A gonadalblastoma?
Yes, you have to monitor for that aggressively. Furthermore, these patients must also be actively screened for Wilms tumor. Missing that screening protocol on an exam scenario will cost you dearly, and missing it in practice is catastrophic.
So given the anatomy, one normal, potentially cancerous testes and one streaked gonad, how are these children managed in terms of gender assignment and surgery?
They are raised as female. The phallus is usually underdeveloped, but importantly, they possess internal female structures like a uterus, a vagina, and fallopian tubes.
And surgically.
Surgically, the absolute priority is the resection of any Y chromosomal material. That means completely removing that residual intra-abdominal testes to eliminate the gonadoblastoma risk.
Oncological control first.
Always. After that oncological risk is managed, feminizing surgery is performed, which again involves a clitoral recession and vaginoplasty.
While we are looking at disorders of gonadal differentiation, how does Klinefelter syndrome fit into the differential diagnosis? It's a slightly different clinical picture, but we need to have it locked down.
Klinefelter syndrome presents in males with a 47XXY karyotype. It's a distinct presentation. Clinically, on examination, you will find tests that are noticeably small and firm.
And their lab work.
When you check their labs, their serum testosterone will consistently be in the low normal range.
How does that specific hormonal profile manifest physically as the patient develops?
It leads to a more feminized phenotype overall as they grow. You will classically see a gynecoid fat distribution, the development of gynecomastia, and a noticeable lack of facial and body hair compared to typical male development.
Got it. Let's move to our final classification category, true hermaphroditism. And let's use this to transition into the reality of patient assessment.
True, hermaphroditism is exceedingly rare. The vast majority of these patients actually have a 46XX karyotype.
What's the anatomical hallmark there?
Anatomically, the hallmark is the presence of both ovarian and testicular tissue. They may have an ovary on one side and a testis on the other, or they might have bilateral ovotest, meaning both tissue types are integrated into the exact same gonad.
How does that dual tissue presence influence gender assignment?
Interestingly, about 75% of these patients are actually raised as male.
Really? Despite being 46XX mostly?
Yes, this is simply because their external genitalia are typically significantly masculinized at birth. Ultimately, sex assignment here relies heavily on the functional potential of the genitalia.
Functional potential.
Yeah, right. For instance, if a patient has appropriate internal female genitalia, they have the potential for future fertility. That potential would strongly support raising them as female, which would then require the surgical removal of any conflicting testicular tissue to align with that assignment.
Let's pull back from the isolated physiology and translate this to the actual moment you are paged to the neonatal intensive care unit at 2 in the morning.
The reality of the job.
Exactly. You walk in to evaluate a newborn with ambiguous genitalia. What is the overarching clinical mindset you need to have in that room?
The evaluation and initial management of a neonate with ambiguous genitalia must be treated immediately as both a medical and a psychosocial emergency.
It's high stakes.
Incredibly high stakes. You are stepping into a room with parents who are intensely vulnerable and confused. This requires profound tact, empathy, and clear communication. And critically, you cannot do this alone. A full assessment must be carried out by a multidisciplinary team, or MDT.
Who exactly needs to be on that MDT to ensure a comprehensive approach?
At a minimum, your team needs a geneticist to handle the karyotyping and molecular diagnostics, a specialist pediatric urologist, and a plastic surgeon for the anatomical assessment and surgical planning, a pediatrician to manage the immediate physiological needs, and a psychologist to support the family.
And the immediate goal of this team?
The unified aim of this team is to establish a precise diagnosis of the underlying condition. That definitive diagnosis is what will safely guide the gender assignment process and the subsequent conversations with the parents.
Let's walk through the history and physical exam, because this is exactly how they will build the clinical vignettes on your board exams. You are taking the history from the parents. What specific details are you listening for that help distinguish these conditions?
Let's start with the most critical historical clue. A detail that examiners love to include in a vignette is a previous sudden infant death of a sibling.
Wow. That is a devastating detail for a family, but an absolutely critical clue for the clinician. Why is that so specific?
If you see that in the history, it strongly points to congenital adrenal hyperplasia. You are likely looking at a sibling who died from an unrecognized severe adrenal crisis and salt wasting in infancy.
That makes perfect sense.
It immediately alerts you to check the current patient's electrolytes and stabilize their adrenal function.
What other elements in the history are you tracking?
You should ask about a broader family history of infertility, primary amenorrhea, or abnormal hirsutism, which can suggest genetic endocrine disorders. You also need to inquire directly about any maternal use of steroids or hormone-based contraceptives during the pregnancy, as exogenous hormone exposure can alter fetal development.
Okay, you've taken the history, and you move to the physical examination. What are the definitive physical findings that rapidly narrow down your differential diagnosis?
The first step is to carefully palpate for gonads in the labial or scrotal folds. The finding of one or two palpable gonads absolutely rules out the masculinization of a female.
It rules it out completely.
Completely. A 46XX patient with CAH will not have palpable gonads descended into the scrotum or labia. Their ovaries remain internal. Conversely, if you examine the infant and find bilateral impalpable tests or a unilateral impalpable testes coupled with hypospadias, that strongly points away from CAH and towards some form of disorder of sexual development in a genetic male.
What about physical measurements? I know precision is key here for plastic surgeons.
You must measure the stretched penile length accurately. The average for a term neonate is 3.5 centimeters. Anything significantly deviating from that informs your assessment of androgen exposure.
And the frenulum anatomy.
You need to closely examine the frenulum. A normal penis usually has a single midline frenulum. A clitoris, on the other hand, usually has two paramedian frenula. These precise anatomical details are exactly what a plastic surgeon needs to document to help the MDT determine the degree of virilization.
To wrap up the clinical pathway for our revision today, let's talk about the lab and imaging workup. We have our physical findings, but what are the gold standard investigations, and how is that final critical gender assignment actually determined?
For investigations, the first line is always a pelvic and abdominal ultrasound. You need to visualize the internal anatomy to identify if there are internal gonads, a uterus, or fallopian tubes present. Then you need genetic confirmation via a full karyotype, which traditionally takes about 2 days to process.
2 days is an eternity for anxious parents waiting in the NICU. Is there a faster way to get preliminary genetic data to guide the initial conversations?
Yes, you can expedite a gross chromosomal evaluation using Esch fluorescence in situ hybridization.
Oh, fascish, right.
This test is specifically targeted at identifying the presence of X and Y chromosomes and can provide rapid preliminary results. Alongside the imaging and genetics, neonatal blood tests must be drawn immediately.
Checking for CAH.
Exactly. You are looking to rule out congenital adrenal hyperplasia by checking electrolyte panels and 17-hydroxyprogesterone levels, and you need to assay the baseline levels of testosterone and dihydrotestosterone to understand the endocrine function.
Then if all the imaging, the genetics, and the blood work still leave the multidisciplinary team in a diagnostic gray area?
If the diagnosis remains uncertain after the non-invasive workup, the next step is invasive. A laparoscopy with a direct gonadal biopsy is required to definitively identify the tissue type.
So, assuming the workup is complete and we have our diagnosis confirmed by the MDT, the family is sitting across from you in a quiet room. How do we systematically approach the recommendation for gender assignment?
Gender assignment is decided only after the diagnosis is confirmed and discussed in exhaustive, transparent detail with the family. The standard framework used to guide this incredibly difficult decision is Meyer-Ballberg's optimal gender policy.
For the sake of the exams and clinical practice, what are the specific pillars of Meyer-Ballberg's policy that we need to evaluate?
The policy requires the team to prioritize 6 intercepting factors. First, reproductive potential, if it is at all attainable. Second, the potential for good sexual function in adulthood. Third, minimizing the number of medical and surgical procedures the child will have to endure.
That's 3.
Fourth, creating an overall gender-appropriate physical appearance. Fifth, fostering the likelihood of a stable gender identity. And sixth, the overarching goal of maximizing the child's lifelong psychosocial well-being.
So practically speaking, when you apply those 6 pillars to the diagnoses we've discussed, what are the standard guidelines for assignment based on karyotype?
Generally speaking, a patient with a 46XX karyotype, who is a masculinized female, like our CAH patients, is assigned a female gender. They have the internal organs, the potential for fertility, and minimizing procedures aligns with a female assignment.
And for a 46XY patient?
For a patient with a 46XY karyotype, the assignment is far more complex. It depends heavily on that stretched penile length we discussed earlier, the anatomical potential for sexual function, and any clinical evidence of androgen insensitivity that would predict brain virilization.
That covers the pathophysiology, the clinical assessment, and the surgical pathways comprehensively. As we finish up this deep dive, do you have a final thought to leave the listeners with as they process all this material?
I do. I want you to consider the rapidly evolving ethical landscape surrounding early surgical intervention. We just outlined that a core tenet of Meyer-Baldberg's policy is psychosocial well-being. But if you look at the field of plastic surgery and patient advocacy today, there is a growing, powerful movement advocating for delaying non-emergency, purely anatomical surgeries until the patient is old enough to actively participate in the decision-making process regarding their own body.
That's a massive paradigm shift.
It really is. How might this shift fundamentally change the plastic surgeon's role in surgical timelines in the next decade? It is something every resident needs to think critically about, because the right answer in a textbook today might not be the ethically right answer 10 years from now.
That is exactly the kind of higher-level critical thinking that separates a mechanically good surgeon from a truly great patient-centered physician.
I completely agree.
To everyone listening, make sure you press follow on the show right now so you don't miss any of our future revision deep dives. If you learned something valuable for your exam prep today, please leave us a rating. Also, we highly recommend you get a premium subscription to listen to the Journal Club and Clinical Cases episodes. They are absolute game changers for your revision and will test your application of these concepts. Finally, we want to hear from you. Leave a comment or a question about today's material on the platform. Keep studying hard, stay focused on the clinical realities behind the textbook facts, and we will catch you on the next deep dive.